Hello everyone, I'm so good to be here. Thanks for the organizers to giving me an opportunity to talk to you all. I am a pediatric pulmonologist here at Riley Children's Hospital. I moved to Indianapolis quite recently, a few months ago from Pittsburgh, where I did my fellowship and training. Respiratory management in neuromuscular patients is one of my special interests, and that's how I'm in charge, along with my colleague Dr. Daftry, in terms of taking care of respiratory health of these group of patients here at Riley Children's Hospital. So I'll be talking today about the acute respiratory emergencies in patients with Duchenne Muscular Dystrophy. Even though this is a neurological disease or a neuromuscular disease, respiratory complications are one of the leading causes of morbidity and mortality in this patient group. So my goal as a pulmonologist, more than taking care of emergencies, which the intensivists are much better than I am, my goal is to keep them healthy and not end up in the ICU and face these emergencies. That's my role as a pulmonologist. So I have nothing to disclose, no financial association with anything. So after a brief introduction, I'll be talking about how does respiratory failure look like in patients with Duchenne muscular dystrophy, how they end up having chronic respiratory failure, how can they have an acute respiratory failure on top of a chronic respiratory failure, and what are the causes? It can be atelectasis, which means collapse of the lung. It can be a pneumonia, which is infection or inflammation of the lung tissue. It can be either an aspiration event or it can be a community-acquired pneumonia. And the other thing which can cause respiratory failure in these group of patients are embolism syndromes. It can be a blood clot or it can be a fat embolism syndrome, which we'll be talking soon. So Dr. Felker, my colleague, already spoke to you about the entire pathophysiology of this disease, so I'm not going to spend too much time on this one. This already Dr. Felker explained, so I'm going to skip this. This is a good question. Why should I, as a pulmonologist, need to get involved about a neurologic disease? So the answer is straightforward. You don't need too much thinking to understand why this is important for we pulmonologists to get involved in the care, because even though this is a neurological disease or neuromuscular disease, respiratory complications are one of the most common causes of these group of patients ending in the hospital. So respiratory disease burden is quite high, so we have to get involved and take care of these patients. So as I said, significant respiratory morbidity, and in spite of we having a lot of new era vaccines, 23-valent and more different varieties of vaccines, pneumonia is still an important cause of death. And pneumonia doesn't simply mean that it's a bacterial pneumonia. It can be an aspiration pneumonia or something different. Even though the vaccines protect you, protect the children, protect all of us with certain bacteria, but aspiration event, which this group of patients are more prone to, so they can develop this pneumonia. It's a progressive respiratory disease because you need muscle strength for your respiratory system to function well. In the absence of this strength, your respiratory pump, which is made up of the muscles, will not be able to deliver the best function. So, as I said, I am a firm believer in preventing the complications. Of course, once there's a complication, we know how to treat it, but I still believe that prevention is much better strategy than actually facing those emergencies, which is not good for us, not good for the families, definitely not good for the patients. So the cost of complications are much higher than the cost of prevention. So this is quite an important point. So who are these patients? Why do a pulmonologist who has special interest in neuromuscular diseases get involved, and who are these group of patients who I need to take care and make sure that their lungs are healthy? So patients with cerebral palsy, Duchenne muscular dystrophy, spinal muscular atrophy, genetic syndromes, chromosomal deletions, metabolic diseases, mitochondrial disease, and so on. And of course, hypoxic ischemic encephalopathy, which means there is a hypoxic brain injury and they have resultant muscular weakness because of that, and so on and so forth. So what is respiratory failure? So the normal function of our respiratory system is to deliver oxygen to the blood to take it to different parts of the body and eliminate carbon dioxide, which is a waste gas which is generated from different cells of our body, and it has to be eliminated through the lungs. So this is the function of respiratory system in our body. So respiratory failure is failure in these two aspects, whether it can either be decrease in the amount of oxygen that is being delivered to our cells, or it can be failure in elimination of the carbon dioxide which is generated inside our body. So we have different numbers here. So if our carbon dioxide level is more than 50 millimeters of mercury, we call it as hypercapnic respiratory failure, which means increased carbon dioxide in our body, which is not good. So if the oxygen levels are lower, which we measure it by PaCO2, which means partial pressure of oxygen in our blood, if this is less than 60 millimeters of mercury, we say that the respiratory system has failed. So these are the definitions. Both these problems, a low oxygen level and a high carbon dioxide level in the blood, can occur at the same time. They are not separate entities. They can overlap on each other and make things worse. So what happens in a respiratory failure? It can be a lung failure, meaning by lung I mean the lung parenchyma per se, which is our alveoli, our capillary system, which are exchanging air, which are surrounding the alveoli and exchanging the air. So there is a gas exchange failure, and this typically manifests as low oxygen level. We call it as hypoxemia in medical terms. And the next is a pump failure. What is a pump? Why do I call it as a pump? Because if you leave lungs by themselves, they don't have the ability to expand by themselves unless the surrounding muscles are pulling them and making sure that they're expanding and relaxing the lungs. The lungs by themselves do not have a muscle in it which will stretch it and make the air get in and get out. So unless we have strong muscles, we will not be able to exchange gas. So by exchanging gas, I mean taking in oxygen and giving out carbon dioxide. So we call it as ventilatory failure. If we are not able to eliminate carbon dioxide, which is a waste gas, it simply accumulates and causes a lot of problems inside our body. And we call it as hypercapnic respiratory failure, meaning the amount of carbon dioxide is actually very high in our body. So when does that happen? That can happen when there is a central depression, meaning if there is a brain injury and the signals from the brain are not getting down to the respiratory system, the respiratory system will not be stimulated and it will not be able to function. So that can happen at that time. Or a mechanical defect or a fatigue. Mechanical defect can be either because of the weakness or because of a structural issue where some structural problem, say for example scoliosis, is preventing proper functioning of these muscles. So this is what I meant by lungs and respiratory pump. So if you see, this is the lungs per se. Here you see the alveolar sacs, the blood vessels surrounding these alveolar sacs, and this is the pump. You can see these muscles, and this is the diaphragm, which is the most important muscle that helps us breathe. So when the lungs fail, when the lung parenchyma fails, you can see that the oxygen level is way too low, and in the ventilatory failure, the carbon dioxide is very, very high. So we call it as hypoxemic and hypercarpic respiratory failure. So this is one slide which I want to spend more time on, because when you are, because you parents are with those special children who can have these symptoms if things are not going in the right direction. Say for example, a neuromuscularly weak patient has a pneumonia. So what signs or symptoms should you be able to look at and identify and seek health care as early as possible before it goes out of hand? So I have divided it into hypercapnic and hypoxemia based on what type of respiratory difficulty the particular child has. So you can see here that one of the first signs to come on when there is a problem with the respiratory system is tachypnea. If someone is breathing fast, it is telling us something that something is wrong with either the lungs or the heart, the cardiorespiratory system. So this is one thing which I want you all to be able to identify, because you know how your child breathes on a regular basis. You know what might be the respiratory rate, say for example 30 per minute or 25 per minute. If that child is breathing 50 per minute, then definitely there is something wrong. I want you all to go home with a message to make sure that you know to identify this sign, because this is not this is easily identifiable. You as a parents definitely can identify that your child is breathing faster. This is simple to pick up. And use of accessory muscles, and you know how much work your child will be able to is actually putting in to breathe on a regular basis. If that is increased, then you should be able to pick that up. Nasal flaring is again one more sign where it's indicating that the respiratory distress is quite significant. So all these things, other things, confusion, increased sleepiness, tachycardia, which means increased heart rate, all these are very important signs which we all can pick up. This I don't expect a parent to pick up, because this is a lab diagnosis, polycythemia, which tells me that on a long-term basis a child has suffered low oxygen levels in the body. So similarly, if there is a lot of accumulation of carbon dioxide in the body, there are certain set of symptoms which are classical for that. Headache, when the carbon dioxide levels are quite high in our body, there is increased blood flow to the brain, and that can cause a lot of headaches. So if your child is complaining early morning headaches, then that's the time when we have to evaluate what's the level of carbon dioxide. We call it as untitled CO2, which we routinely do in our clinic. We have to make sure that they are not hypoventilating, meaning they are eliminating adequate carbon dioxide or not, has to be determined when they start complaining of headaches. So flapping tremors, this is classically seen, but if someone is neuromuscularly weak, this might not be the sign which you can pick up. But again, as all these are lab features. So I went through this already. So uncomplicated hypercapnic respiratory failure is very typical in patients with neuromuscular disease. They, before even getting hypoxic failure, which is can happen at the terminal stage, on a regular basis, if they have significant neuromuscular weakness, if their respiratory system is failing, this is the first type of respiratory failure they will have. This is a hypercarbic or hypercapnic respiratory failure. And this can be quite well managed by non-invasive ventilation. It doesn't mean that they have to get tracheostomy. It doesn't mean that they have to get intubated. We have fantastic machines these days, quite compact, less than the size of a laptop, which are able to breathe or assist the breathing in your children. I think we all should be aware of that, make use of them. I'm a big advocate for starting this BiPAP as early as possible, as early as the child needs. And we have enough tools, pulmonary function tests, spirometry. We do collecting a lot of objective data to gather all this information, which makes them eligible for these kind of equipment. Say, for example, peak cough flow. We measure how good of a cough they have. If it is 270 milliliters per second of peak cough flow, it means their cough is pretty good. What if they have 150? It means their cough is not adequate. Then they become eligible for a device called Cough Assist, which will mimic their cough and try to clear all those secretions which have accumulated in their lungs. So for us to help you, I think we need to see these children on a regular basis and identify issues and weakness which is compromising their breathing at a very early stage and try to help them out as early as possible. So I thought, I tried to pull up a picture from the internet to help, a non-medical personnel to understand this respiratory failure. So this is our airway. When we suck the air in, it goes inside, and this is where it ends up. This is called the alveoli. And the alveoli is the adjacent structure to the alveoli is our capillary membrane. So this is where the gas exchange takes place. This is the air comes here. The green dots is actually the oxygen molecules, and it's crossing this exchange barrier and getting into the blood, and this goes to the heart, and heart pumps it everywhere in our body. So what can cause respiratory failure in a patient with Duchenne muscular dystrophy? So it can be secretions. Okay, so when does this secretion, if you can see here, the secretions are actually blocking this air from even getting into this capillary for gas exchange. When does the secretion start accumulating? This is when there is a pneumonia. It can be an aspiration pneumonia or a bacterial pneumonia. Pneumonia is essentially accumulation of a lot of these infected material into the alveolar sacs and preventing the gas from reaching the alveoli, reaching the capillary for the exchange. So it can also happen if there's a mucus plug. If the child is not able to clear the mucus sitting inside the lungs, that can actually plug the airways and block the airway. So essentially the air is not able to communicate with the capillary at all, and this leads to low oxygen concentration in the body. So embolism syndromes. We all know that cardiac weakness, the weakness of the heart, is quite common in patients with neuromuscular disease, and a weak heart tends to dilate at some point. When it has dilated, the dynamics of it is quite disturbed, and when the blood is not moving around as nicely as it should, there is tendency for developing clots inside the heart, and these clots can go anywhere in the body depending on where they are formed, whether it is formed in the right side of the heart, left side of the heart. Based on that, they can go into different parts. The other important factor which my intensive care colleagues will talk very soon is fat embolism, but I'll leave it up to them because we are running short of time. So this is how a pneumonia looks on a chest X-ray. As you can see here, because of pneumonia, there's a lot of accumulation of secretions, and this is preventing gas exchange. And this is how a pneumonia looks on a chest X-ray. And this is atelectasis, which means collapse of the lung. Say, for example, the child is not able to cough out things properly because of neuromuscular weakness and not able to clear that mucus which is sitting there in the lungs. So that has tendency to block the airways and prevent the gas exchange. And this is how the atelectasis or lung collapse looks like. And this is the lateral part of the same X-ray. And this is the mechanism how it leads to decreased oxygen levels. And this is a CT scan of a patient who had a blood clot in the major pulmonary artery. You can see this lighted up thing is actually a contrast. They pushed contrast in this child, and this lightened part is actually supposed to look like this, but it's not looking like that. It's looking a little dim there, which means there is a solid material sitting there and blocking the circulation of the blood. So this is a thrombus or a blood clot sitting there and blocking the airway. Severe scoliosis. This is again one of the significant problem in patients with Duchenne muscular dystrophy. It causes restrictive lung disease. Okay, so it alters the normal aerodynamics of the lungs because of the altered orientation of the airways, altered stretch on the muscles, because you need adequate or proper stretch for the muscles to perform in a right way. We call it as length and tension proportions. So you need an appropriate length and the tension on the muscle for it to contract in a strong way. So that is disrupted when there is a scoliosis, and it can push part of the lungs and make it collapse. And it also can push on the heart and make the hemodynamics a little altered. So it disrupts airway clearance too. So even if the child is trying to cough, because of the scoliosis, it might not clear the secretions very well. So all these things can lead to issues. So is giving oxygen an answer to all the questions? When we see low oxygen saturation on pulse oximeter, does it mean that we have to give oxygen all the time? So that's not the answer all the time, because sometimes it can be hazardous. So children with neuromuscular weakness tend to have a baseline increased carbon dioxide level in their body, and that actually is stimulating the the respiratory center in our brain and telling the lungs to breathe. And if we give them oxygen when their carbon dioxide level is quite high without knowing that there is underlying respiratory failure or underlying increased level of carbon dioxide, we are actually eliminating that stimulus to the brain, and the child might stop breathing. So if a child who is on oxygen on a regular basis and for some reason you see all those signs of respiratory illness, increased work of breathing, increased increased respiratory rate, increased heart rate, before you actually turn on the oxygen to 4 liters, 5 liters, please make sure, give us a call. We want to measure the carbon dioxide level and make sure that there's no underlying failing respiratory system before we let you increase the oxygen. So oxygen is not the answer. That's the bottom line point I want to make. So we are in a new era. As you just heard, senior speakers here before me, therapeutic nihilism is not appropriate anymore. It's unacceptable in this era where we have a dedicated team in our hospitals, in our cities. We are trained to take care of these patients. We have groups of and dedicated people who are coming up with these organizations, little organizations who are making huge impact in the world in terms of increasing the research, increasing the funding for the research, and so on and so forth. Nihilism is unacceptable. We cannot do that. So new technologies are available, as I said, breathing technologies, and I'm sure you all are quite active on social media, and I encourage that, to be active on social media, get to know things, what are happening in the world, and try to be informed. I think that is very important. So American Thoracic Society is with you all. We all meet once a year to go over the guidelines as to what important protocols we have to follow to keep these children healthy. And one of my professors who trained me is actually one part of this. He has been active, he has been first author on all the major American Thoracic Society papers that have come out. Thank you so much.